Good morning. Today's class is about the diseases that affects the salivary glands. Now we know that the human body has major as well as minor salivary glands. The major salivary glands are air glands, and they are the parotid, submandibular, and the sublingual gland. The major salivary glands are also serous, mucous, and mixed. The parotid gland, which is one of the largest salivary gland, is a predominantly serous, or serous in the sense it has got a very thin, watery saliva. The sublingual gland is a mixed gland, but predominantly it is a mucous gland. That means the saliva that is produced from the sublingual gland is very thick and ropey. The submandibular gland is a mixed gland, but it's predominantly serous, and it is the largest. It produces the largest amount of saliva. Around 70% of the saliva in the oral cavity is produced by the submandibular gland. Now, as we come to the content of the saliva itself, we see that it is made up of water, electrolytes, urea, ammonia, glucose, fats, and proteins. What are the functions of saliva? It's a lubricant which allows the food, especially the dry food that is being masticated in the oral cavity, is mixed with the saliva, and it moves down the esophagus into the stomach, and this saliva acts as a lubricant for this movement. It is also immunologic. That means it has certain elements inside which prevents infection or protects the oral cavity from the bacterial or viral attack. It is also digestive. There is a enzyme called the salivary amylase, which is present in the saliva, which actually helps to digest the carbohydrate that is ingested. Now, that is why they say that we have to chew our food properly before we ingest it into the stomach, because the digestion starts in the oral cavity. It has also got cleansing properties. It cleans the mouth by the flushing action of the saliva against the teeth and the mucosa. It removes all the food debris in the oral cavity. The parotid gland. As you come to the major gland, the parotid gland, the anatomy of the parotid. It is the largest pyramid gland. It is shaped like a pyramid with the base at the external auditory meatus. The apex is at the angle of the mandible. So it's kind of an inverted pyramid with the base in the near the ear, and the tip or the apex forms towards the angle of the mandible. It has two lobes, which is connected by an isthmus at the posterior part of the gland. So behind the gland, the posterior part, there's a connection to the deep lobe of the parotid. It also has a fibrous capsule, which is a thick fibrous tissue that surrounds the salivary tissue. Now, the importance of that we will talk about later on. The duct that emerges from the gland, which carries the saliva, is called the Stenson's duct, and it pierces through the buccinator at the anterior part of the gland. The buccinator forms the cheek muscles. So the duct actually pierces the buccinator and comes out into the oral cavity. The parotid gland, we take the clinical consideration. It has a fibrous fascia which covers the salivary tissue, I said earlier, and this covering makes the inflammation of a salivary tissue very tense and very hard, because it covers or attaches itself. This fibrous fascia covers the gland, and an acute infection which brings about inflammation stretches this fascia, which makes it very painful. Stagnation of saliva can occur in the duct due to the wide duct and the right angle turn right angle turn as it enters the oral cavity. That makes a right angle turn at the first molar, or the upper first molar area. It enters into the oral cavity. That's where the stagnation also is common, the stagnation of saliva, pooling. Now, the anatomy of the submandibular glands, we know that it is located at the submandibular space, which is a fossa kind of space, which is in the mandible, in the lower board of the mandible. So we have seen the mandible. If you remember the osteology of the mandible, we find inside, or the lingual side of the mandible, you have a depression which actually lodges the submandibular salivary. The duct that secretes saliva or brings the saliva to the oral cavity is called the Wharton's duct, and it starts at a deep part of the gland. It turns sharply at the posterior border of the mylohyoid muscle and then opens at the sublingual papilla. Now, the submandibular gland and the duct, the importance of the duct and the gland is that it is placed at a lower level in the oral cavity, and that makes it prone to infection. Now, because it is present at the lower level, the opening of the duct is at a higher level. It is at the floor of the mouth. As we know, the submandibular duct travels from the posterior part of the oral cavity, and it lies in the floor of the mouth and then opens in the sublingual frenum, so, or the lingual frenum, just adjacent to the lingual frenum. And the gland is lying below the opening of the gland. So basically, it has to work against gravity to push the saliva from the gland into the oral cavity, and that makes it very prone to recurrent infection. And also in the anatomy, we find that there is a widening of the duct before reaching the papilla. The papilla is always a very small constricted part of the whole duct, and the rest of the duct is quite wide, and the bottleneck is the papilla, and that also can bring about chances of infection, because that opening can be blocked by a salivary stone or some other structures that can prevent or it forms a barrier for the flow of saliva. Also, the duct itself has a long and a tortuous course in the oral cavity, and there is also a sharp bend of the duct at the posterior border of the mylohyoid. If you remember the anatomy of this, the submandibular gland, as we said, it is in the fossa, submandibular fossa, and then the duct actually starts not at the anterior border of the gland, but at the posterior border of the gland. And then it makes a sharp bend along the posterior edge of the mylohyoid muscle, and rises above the mylohyoid muscle and runs in the floor of the mouth, and then it opens in the anterior part. Now, the sublingual gland. Like I said, it is a mucosalivary gland. It is present in the sublingual space. It has got an anterior and posterior parts. The ducts are made up of not one single duct, but small multiple ducts that opens through the sublingual folds. They have short ducts and stasis is less. So because it has short ducts and it doesn't have a long tortuous course, the chances of saliva pooling or stasis is much less. The minor glands can form mucoses due to its superficial occurrence. So we just talked about the major glands, and the minor glands also is a small glands which is spread all over the oral cavity, except the vermilion. We don't find any salivary part or opening into the vermilion, and that is the reason why we have our the vermilion part of the lip is very dry. It's always dry. We have to keep it moist by either wetting it with our tongues, or sometimes we apply some sort of cream or Vaseline to keep it wet. So these minor glands are present in the lips. It is present all over. Even in the pharynx, you have minor salivary glands, which are small glands which have small openings right into the mucosa. The physiology, now we spoke about the anatomy, now we come to the physiology of saliva. What is the function of saliva? So I said earlier, it's an antibacterial also. So how immunoglobulins are present, which basically attacks the bacteria and virus and destroys it. Lysozymes, lactoferrin, sialoperoxidases, histamine, all these are present in the saliva, which acts as antibacterial. Another function of saliva is maintaining the integrity of the mucosa. Your mucosa, sometimes, if saliva, if there is some condition called xerostomia, which reduces salivary flow, you find that the oral cavity breaks down and forms ulcers very quickly. Now, the presence of saliva maintains the integrity of the mucosa. What helps is the peptides like epithelial growth factor, nerve growth factor, stomatostatins. All these factors or peptides actually helps in maintaining the integrity of the mucosa. That means reduces ulcer formation. Now, I spoke about digestive action. Enzymes like salivary amylase, which is basically breaks down carbohydrates, and then you have salivary lipase, which breaks down fat. Those are present in the saliva. Now, this particular screen, I showed all the diseases that can affect salivary glands in human body. Now, if you see the top part, if you see the top part, it's made up of the congenital diseases that affects salivary glands. And you find that there is aplasia, atresia, and aberrancy. So aplasia, atresia is absence of the duct, aplasia is absence of the gland, and aberrancy means ectopic gland. That means you find glands where you usually don't find them. That is aberrancy. The second classification is the enlargement of glands. So enlargement can be due to inflammation and enlargement due to other factors, which is non-inflammation. Now, enlargement due to inflammation or inflammatory enlargements are caused by viral, bacterial, allergic, sarcoidosis, and obstructive. So these are the causes that is very common in the salivary infections. Then you have non-inflammatory, which is made up of autoimmune disease like Sjogren's syndrome and Wicklick's disease. Then alcoholic cirrhosis also causes swelling or enlargement of the gland. Diabetes, long-standing diabetic patients, you find that the salivary glands are enlarged, especially it is even alcoholic cirrhosis and diabetes, you notice the parotid glands are swollen bilateral. Certain nutritional deficiencies and HIV associated. So those were the causes for enlargement of the gland. Now you have the third factor that causes disease process in salivary glands are cysts. Three types, actually extravasation cyst and retention cyst, and the third one, which is actually a retention cyst itself, but specifically affecting one of the major salivary glands, which is sublingual gland, is called the RAN. Now we come to each types in detail later on, so I will not spend time here. So the fourth kind of disease process is tumors. tumors can be benign and malignant, and there are multiple types of tumors. You might have to look up the textbook, but these I have just included a few and very common ones. And the benign tumors are the most common would be the pleomorphic adenoma. Then you have Wathin's tumor, basal cell adenoma, myoepithelioma, and other very rarer types. The malignant tumors, the most common is a mucoepidermoid carcinoma, and the next common is adenoid cystic carcinoma and malignant pleomorphic adenoma. So these are the most common malignant tumors. There are others also, but very rare. The fifth classification is a very isolated or a specific kind of disease process called necrotizing pseudometaplasia. The thing is, this is separated from every other classification. It's not due to, it's not an enlargement of the gland, it's not a cyst, it's not a tumor. It's a separate entity. We talk about that as we come to that part. Now, the sixth is a salivary gland dysfunction, that is physiological dysfunction. It's caused by either xerostomia or siluria. Now, xerostomia is dry mouth or decreased salivary secretion, and siluria is the opposite, which is increased salivary secretion. Now, we start with salivary gland dysfunction, siluria or chiasm. Excessive salivation is called siluria. It can be mild, intermittent, continuous, profuse drooling, and minor due to local irritation, aphthous ulcer, ill-fitting dentures. So these are the causes of increased salivary production. Now, you can also have certain condition called idiopathic paroxysmal siluria. They produce, these are in minor or mild forms. Now, you get profuse drooling, which is very seen in rabies and heavy metal poisoning, lithium poisoning, cholinergic agonists, mental retardation, cerebral palsy, and sometimes even after resection of the mandible, the salivary secretion increases and it starts collecting inside the mouth, and the patient is unable to swallow the saliva produced and forms profuse drooling. So how do you treat it? So drug-wise, you can start on some anticholinergic medications, behavioral modification, physical therapy, submandibular resection. Sometimes the whole gland is removed, and even if you're not, especially in mental retardation or cerebral palsy, there is a continuous drooling. We sometimes remove the gland, or sometimes we do what is known as a transposition of the duct, especially parotid duct. You can dissect out the parotid duct, which starts from the opening, which is in the upper molar region, and you dissect it out, and then you turn it backward into the pharynx, and then suture it into the some pharyngeal tissue. So those are the ways by which you can reduce the amount of saliva. Also, parotid duct ligation is another process. Now, the opposite is this xerostomia, which is a subjective sensation of dry mouth in the oral cavity. And we find that women, unfortunately, are affected by it much more than men. And older, obviously, older individuals are greatly affected than younger. And because the older individuals, the salivary glands reduce, production of the saliva secretion is reduced. Some patients will take medications like antihistamine, decongestant, antidepressants, antipsychotics, and antihypertensives. These patients also complain of dry mouth due to xerostomia. The other causes can be salivary gland aplasia, aging, excessive smoking, mouth breathing, local radiation, Sjogren's syndrome, and HIV. When you get how does it present clinically? Presents as a dry mouth. Patient says his mouth feels dry. That is a subjective sensation. That is why I said it's a subjective sensation of dry mouth. And when you look inside clinically, you find ropey, thick, and foamy saliva. So there will be some amount of saliva, but it will be scarce, and that causes a ropey thickness or foamy kind of saliva. And very commonly, the teeth and the oral the mucosa are affected by candida and caries. Treatment is conservative. That is, there's no much treatment modality available at the moment, especially if you have a Sjogren's syndrome, which is an autoimmune disease, and chances of correcting that is very, very minimal at the moment with the technology we have. So how do you treat it? Maintain oral hygiene, avoid these patients, or prevent caries and candida and other infections in the oral cavity. And silagogues or certain drugs that can increase saliva secretion, like pilocarpine, are also administered, and modification of medication in people who are taking xerostomia inducing medication. So these are certain ways by which you can control, and also you can ask them to sip water periodically so that their mouth is kept dry. And another method is there are saliva replacements, either by lozenges, sprays, or even liquids that can coat the mouth, as you can take a small spray and to spray it into the mouth, and there will be a thin layer of saliva which forms, which reduces or removes that dry sensation in the oral cavity. Now we come to silolithiasis, which is a stone formation of salivary calculi in the duct of gland parenchyma, resulting in obstruction of flow of saliva. 90% is observed in the submandibular gland, because you know there is a curve and a tortuous course for the duct, and also because the gland is located below and the duct opening is in a higher plane. Just because of the position, and due to high calcium content of its secretions. Other causes that are like local irritation, drugs can cause stagnation leading to calcification. Silolith is the calcified mass with the laminated layers of inorganic solutes and can grow to approximately 2 centimeters. Calcium phosphate, form of hydroxyapatite, octacalcium phosphate, etc. These are the structure or the substances that can form silolith. I think we'll stop now. We'll continue in another class.